Welcome to the AA Podcast, our little corner of the web where we are not afraid to discuss tough questions like,
when did nutrition, health, movement, and stress management become alternative medicine?
Where we embrace challenges in all aspects of life to become healthier and stronger versions of ourselves.
And where food and movement are the best kinds of medicine, and cooking meals at home is a revolutionary act.
Hello and welcome to the AA Podcast. This is Ashley Olson.
And I'm Andrea Crane.
We have a special podcast on our end because we are not across state lines. We are sitting in the same room.
We're actually across the room.
Across the room because technology is so fun. We don't have the right inputs to be able to record into one thing. So we are trying to record into this how we normally do, but we're trying to see each other. So Hi.
We're literally like sitting 20 feet away from each other, waving over the computer top.
It's ridiculous. But yes, I am in Idaho this weekend. It's been a kind of a dreary, well, yesterday was sunny.
Yeah.
Today's kind of dreary. So we are doing all things podcast today.
Mm-hmm.
So it's kind of fun. But today, before we get started, we are going to share our weekly Bible verse. And mine is kind of tongue-in-cheek. But mine is coming from 3 John 1, 13 and 14. I had much to write you, but I would rather not write with pen and ink. I hope to see you soon, and we will talk face to face.
That is so appropriate. We have had like the best time face to face. All right. So my verse is because we're talking about primary care visits today. Listen to advice and accept instruction that you may gain wisdom in the future. So hopefully we're dispensing wisdom in these office visits.
Yeah. So when Andrea first started with primary care, she was telling me like, oh my gosh, this. And I'm like, wait, that's not normal. And so I was like, we need to do a episode on primary care and like what's some misconceptions of what people think when they come to see a doctor, even establishing with a doctor, like helping you guys and me know, hey, this is what the doctor is expecting as far as structure goes and what they are needing to be basically hopefully the best primary care provider for you. So I'm gonna learn right alongside you guys today, and so if you have any questions, definitely hit us up on our Instagrams or our email. Our information is always linked in the show notes below, so check that out. But Andrea, why don't we start off with like some basic 101? What are some types of offices that one might visit?
Yeah. So, and just to piggyback off of what Ashley said, this was honestly, all of this information was kind of new to me too. Being in nursing and then moving into a provider role, this has been an education in terms of like what types of visits are offered in a primary care office. And I just thought, wow, when I was talking with Ashley, complaining to Ashley about some of the problems we encounter, she's like, listen, people don't know this. And then I thought back and thought, well, that's probably right because I didn't know it either. So yeah, let's talk about some of these different types of offices. So first of all, I'd like to talk about the types of primary care offices that you can go to. And so these would be like different practice settings for primary care providers. And the first one and most common one, and in fact, I work in this setting as well, but this is an insurance-based office, okay? And this type of office will very often accept all the major insurance plans in your area. Now, I want to say a few things about that. First of all, there we can kind of divide these insurance taking offices into two categories. So what you have to understand is that insurances, like all the major carriers, will reimburse at approximately the same rates, meaning that when I, as your provider, or my office more so, when my office bills your insurance company for the visit that I spent with you, um, all the major carriers will pay us about the same amount of money. Okay. So then there is the realm of what's called CMS, and this is the Medicare and Medicaid services. So these are government issued insurance plans. All right. And so these are just absolute garbage reimbursements. And so when, we can bill like for a $200 visit and they will pay 60. So it's really, really poor reimbursements. And so all that to say, it's harder to survive when you have a lot of Medicare slash Medicaid patients. So Medicare is, people over 65 or over 60. I don't work in a CMS taking office, so I don't know the particulars there. I believe it's over 65. But anyway, Medicare and then Medicaid is for low income recipients, and it doesn't matter what age. So if they age out of Medicaid, they can get onto Medicare afterwards. Now, offices sometimes will elect not to take Medicare and Medicaid. All right. So if they do that, the primary reason is because you can't afford to do the care for the reimbursements that they're paying. And so, if you're calling around to offices and you've got Medicare, it's getting increasingly difficult to find places that take it. Now, I also want to speak to the credentialing process. So this is another hurdle that primary care providers face when going into practice, is that you actually physically have to become credentialed. You have to become an authorized provider for each and every insurance plan that you are going to take. And that I've been in practice here at where in Idaho for 4 months, and I am still waiting on credentialing from many insurance companies. And so my office has to pay a third party to administer all of this credentialing. There are so many documents that have to be filled out for each insurance company. They look through my licensure, they look through my academic history, they look through like they do a criminal background search. They do all kinds of searching and digging into my background in order to credential me as an authorized provider that can take their insurance. So I'm 4 months in, and there's really no end in sight. I don't know how long this is going to take, but in the meantime, we have to bill under the clinic owner's information, if that makes sense. So yeah, it's just I don't think patients often understand just how difficult it is and how circuitous the path to be able to take your insurance and to be able to provide that service to you for a copay rather than a cash pay. So yeah, it's a lot, right? Ashley's over there nodding like holy cow. Yeah, so hopefully that's a little bit enlightening. Now, I also want to mention, if you are not a CMS provider, meaning you don't take Medicare and Medicaid, there are some restrictions. So, we're a functional medicine clinic, but we're also a family practice clinic. So, that's where I work. And we've got lots of Medicare patients that would like to pay cash, right? So, that seems like it should be okay. If somebody wants to pay cash for a service, why can't they? They can't. We are in danger at that point if we take cash from a Medicare beneficiary, then we have committed fraud. Yes,
Wow.
yeah. So we have to be very careful. Like if somebody is of a certain age and they're calling and asking about an appointment, most people of a certain age have Medicare policies. And if they do, we cannot take them on as even a cash patient. Isn't that crazy?
That is really and crazy.
Yeah. So a lot of times people don't understand that. And, I want to get in to see a functional medicine provider and I want to pay cash. Why are you stopping me from doing that? It's like we would love to take we would love to take care of you. We would love to be your provider, but the system just doesn't allow it. So we can get in big trouble for that. Um, Now, so that is the insurance based setting. Now, most patient panels, when I talk about a panel, that is how many patients each provider is responsible for. So, a typical insurance based model where they don't do functional medicine, the average patient panel size has been stated at 2,500. So that's 2,500 lives that you see and that you care for as a provider. Now, these folks are supposed to come in for annual visits. They're supposed to come in for, if they've got a chronic health condition, they need to come in for quarterly or biannual visits. You've got screens like PAPs and blood work and all of these things. So extrapolate that out. Plus you've got the acute sick visits. Plus you've got ongoing care. So it's a lot. That's a lot of people to care for. Um, and so, but that's what it takes to survive in general practice. Now, it has been said that in order to care for these people appropriately, that a provider needs to work 21.7 hours a day in order to properly care. This is not even functional medicine. This is to properly care for in a conventional sense. They have to work 21.7 hours a day. Now, obviously, you can't do that.
You are only allowed
That's right.
2.3 hours of sleep a day.
That's right. That's right. So, yeah. So when you're wondering why you go to the doctor's office and they spend 3 minutes with you and you don't feel heard, um, that's why. And it's not that they don't want to spend time with you. It really isn't. I can assure you of that. Now, a lot of providers get burnout and they may act like they don't want to see you because
Yeah.
there is a high degree of burnout in this profession. But you're kind of seeing why.
Which
There.
is crazy because I mean, I know the amount of time and effort you put into just getting this credential
Yeah.
license and
Mhm.
like just all of that. So then you almost feel a sense of relief when you graduate, but then
Yes.
that's really not even like
Yes.
the cusp of it. Like
Yes.
you get thrown in. I mean, for example, yesterday Andrew was supposed to have off and she had this emergency call
Mhm.
and she's not getting paid for it.
Yeah.
Like
Yeah.
but she had to put on her doctor's hat and put on her practitioner hat, whatever you want to
Mhm.
say,
Yeah.
and take care of this. And this is outside of her time, quote
Mhm.
unquote, in the office. This is not extra time. This is not bonus pay. Like this is just what she does because she has a heart to help people.
Yeah. Yeah, that's what the job is. So you kind of jump out of the frying pan into the fire when you go into practice. But I also know that when you're called to do something, like when you feel as though this is your vocation and your calling, you can't not do it. Like there's nothing you can do. You're supposed to be doing this, so you're given strength for the task ahead. But yeah, it's daunting. So let's move on to another type of service that there is. So there are more and more primary care providers are looking for, how can I do this differently? How can I keep myself from burning out? How can I hold my family together? How can I have work life balance? I'm taking care of all these other people. And this is the thing in primary care, like you sit all day long, and all day long I'm telling people, you have to get up, you have to move, you have to. And I will say, like, I am in such an amazing situation in my work. I work in, hands down, the best office I have ever experienced. We have great work life balance. We take care of each other. We are definitely like a work family, and I work with the most amazing women I've ever worked with. And so I'm so blessed and fortunate in that regard. But the realities of the job is that as a provider, you sit and you sit all day, and then you come home and sit while you finish work. And so it's hard to find that balance because all day long you're preaching to your patients, you got to move, you got to move, you got to move. Set that alarm on your watch, get up, take a few steps, do some wall sits, do some air squats. And yeah, we find ourselves in the same position where we can't you know get up and do all the things we want to do. um, so the next type of office is a fee for service office, otherwise known as like a cash office. So this is someone who has elected not to take any insurance, and you can come in and for a specific fee you pay to see the doctor. So a primary care visit might cost you $125. An acute care visit might cost you $100. Maybe you pay $30 for a urine dip if you have a UTI. So there'll be cash fees for everything that you get done in that office, but they're all up front. It's like a menu basically. And so that for people that don't have standard insurance, that have like some of these co-op plans like MediShare, which is awesome. But then also some people just do like a super high deductible plan that's less expensive per month, but it doesn't cover anything. And your deductible is like, $10,000. And so this is kind of a cheaper option for some people. Now, then there is uh, what's called a well, let's talk about concierge first. So this is the bougiest of all of the medical models. So when I say concierge, I know it conjures up visions of like, a doctor who is on call for you all the time, and you can just like call them up and say what you need, and you get right in, and they call you back, and they're texting with you and emailing with you, and you have immediate access to that person's life all the time. Yeah. And so you are going to pay a lot of money for that. And these folks, concierge medicine, they have very small patient panels. But even so, they still have between probably 1,000 and 1,200 patients that they're taking care of. Okay. And you, like I said, you are going to pay a lot of money for that. It's probably going to be, I would say, anywhere from 250 to maybe $600 a month for concierge medicine. Then there is a little less expensive option.
But on top of that, like if you're
Mhm.
ordering labs or if you're needing, it's on
Oh,
top of that.
oh, you betcha.
Yeah,
Yeah.
yeah, yeah.
Oh,
So
yeah.
you're just paying for the service,
Yep.
not for all inclusive.
Exactly. You are literally paying for access, and you don't have to wait. Now, but let me throw this in there too. You're also paying not just for access, but for their time. So
Right.
if you have a complicated condition, uh, there is a possibility that you would not be a candidate for a concierge practice, because if you take up an inordinate amount of time with your condition, it doesn't work. The
They don't
model
have the
doesn't
time
work.
capacity.
That's right.
Yeah.
Yeah. So anyway, but you do get more time with a provider in a concierge setting. Now, there is sort of a quasi concierge, and this is really, when I was in school, this was a very interesting model to me, and I've done a lot of thinking about this. I've done a lot of reading about it and a lot of case studies on providers that are making this work. So if you're a provider and you're listening to this, there's a lot of very good evidence out there that this is kind of the way to go. Primary care, or DPC, is the next model, and it's like a combination between a fee for service and a concierge. So they have a little bigger patient panels, but they cost less. So they're more accessible to people that maybe can't afford a concierge practice, but they want that accessibility. And again, not a super medically complex patient. They're just looking for standard primary care. Somebody to be there, somebody to do screens and checks, somebody like, if I call and my kid is sick, I want a phone call back in an hour or 30 minutes or whatever it is. And so, yeah, that's what you can get with DPC. So that's also a great model, but patients are going to pay cash for that,
Okay.
right? That is always going to be cash.
So not taking
Nope.
insurance. Okay.
Nope. Because insurance, remember, the provider can bill whatever they want to the insurance company, but they're only going to pay X amount,
Mhm.
period. And
Mhm.
so because DPC costs more, yet fewer patients, it costs more to provide. Uh, the provider needs to be able to say, no, your monthly premiums are going to be anywhere from between, I've seen them for $75 a month for an individual, or I've seen them up to like $200 a month for the individual. Okay. But when you think about it, 75 bucks a month or $100 a month for a healthy 30-year-old, like that's the way to go.
Right.
So
Especially, yeah, if you don't have health issues.
exactly,
Yeah.
exactly. Um, now, uh,
Are they harder to find?
yes, they are, but they're becoming increasingly easy to find because, like I said, primary care providers are jumping ship. Like this
Mhm.
is a high stress, high demand kind of occupation.
Okay.
Yeah.
And then they're not maybe labored as much with the charting codes and I mean, you still have to chart, but
Girl,
like we're
you
gonna get
hit
into
the
that.
nail on the head. That is exactly right. So when we talk about work-life balance, and I'm going to talk next about the time, like, when your doctor spends 7 minutes with you, I'm going to tell you why it's not just 7 minutes. I'm going to tell you exactly what that time is spent doing. And a lot of it is charting for
Yeah.
insurance companies. So I was explaining to Ashley yesterday that we bill for certain codes, right? And based on your complexity. Um, and so if I bill a really complex code because you're a super complex patient and I spent hours trying to figure out what plan of action we're going to follow, interpreting your lab results, etc. Or sometimes I have to study up on a rare condition that I haven't treated before. That all goes into the codes that I bill. I have to justify that code based on my charting. And so everything that I did, everything that you and I talk about has to go into the chart and it has to be manually input by me. And generally that happens at night when I come home and you're talking about, one thing I forgot to mention, how many patients are we seeing a day? So when I'm talking about charting, in a regular insurance model, they'll see anywhere between 15 and 40 patients a day.
Wow.
Okay. Now think about charting on that many patients.
Yeah.
Now I'm in an incredible setting where I see between, I'd say, 8 and about 14 patients a day. Okay. Now, still, that is a lot of work because I see a lot of medically complex people. But if I didn't have to chart for insurance companies, that would cut my work in half. So I wouldn't have to do the billing codes. I wouldn't have to do the diagnostic codes. I could just chart for myself or for any other provider that was coming behind me to help take care of you. I could chart for us, just straight clinical notes, not insurance based notes. Um, let's see. Let's talk about the time that it takes for these visits. So when a standard provider comes in and sees you for 3 to 7 minutes, what's the other part of that time? So you call up, you get an appointment, you probably assume that you have a 30-minute appointment, right? Or an hour appointment, some people assume. um, but let me tell you what happens during that time. So you got to have a medical, you got to have the medical staff, right? And then even before you get there, so if I have 14 patients on my panel the next day, I will sit for probably 2 to 3 hours the night before, and I will prep for each one of those patients. And that includes going back through some of your previous notes. I can't obviously go back through all of the notes. I cannot go back through 100 lab reports from 5 years ago, which I get asked regularly. Well, I turned that lab in from 2018. Did you see that? No, I didn't. but I did look through your last several visit notes, and I know where we are, and I looked at your last lab report. So yeah, that time is spent preparing for you, and then you show up, and there is a front office person that checks you in, and the clock starts when you walk in the door. And so they check you in, they may give you some paperwork to fill out. Then a medical assistant will come out and they will bring you back. They will check your vitals for me, and they will get your temperature, your blood pressure, your height, your weight, all of that information that goes into my chart. So at least I know I've got a hemodynamically stable person sitting in front of me, because sometimes people will come in for a primary care visit and their blood pressure is just through the roof. Like I've sent, not at this current practice, but at in clinical rotations, I've sent many people to the ER straight from their primary care office. I've had ambulance crews come and pick them up because they
Wow.
were not stable. So yeah, I mean, you see everything. But yeah, so they get your vitals, they put you in a room, they ask you some questions, and then they will come and relay that information to me, either verbally or through the computer charting system. I'll see that information pop up. So all of that time is considered part of your visit time, because all of that is information being collected. Then I look at that information. Is there anything new here that I need to take into consideration? I have questions that I want to ask you that I've made notes about the night before. And then I go into the room and we talk. Now, I also wanted to put a plug in here for when the medical assistant or the nurse at the office collects your vital signs. A lot of people, women in particular, they don't want to get weighed. And I totally understand that. Here's what you can do. So it is considered a vital sign, all right? Um, it is in a primary care setting. It is part of your vitals. It's not like an ER vital sign, but it is a primary care vital sign, and I need to know, because if you are, if you're a heart disease patient and you've put on 15 pounds since I saw you last week, then you are probably not hemodynamically stable. We need to get some fluid off immediately. So there's lots of reasons why we have to know this, but if you struggle with disordered eating, if you are struggling with weight loss, if you are struggling with weight gain, there are all kinds of problems and all kinds of reasons why people may not want to be weighed. Just ask to turn around. Just say, hey, can you keep that from me? And they absolutely will. So you will pop up there, you'll face the other direction, or they'll cover the number on the scale for you. But they will absolutely be sensitive to that. So you don't have to, if that is traumatic for you for some reason, or you feel like it's going to throw you off course, then just mention it. And they would be so happy to keep that number from you.
Absolutely. Yeah.
Okay. Yeah, so that's once I've talked to you, then I'm going to do a physical exam based on our conversation. Now, again, the clock is ticking, right? All of this goes into that, 15 to 30-minute visit that got scheduled. And so I talk to you, I do a physical exam, only what's necessary, right? Based on our conversation. That's how we're taught. And then I order labs or tests or imaging or whatever it is. I might need to order an MRI. I might need to order an X-ray. I might need to order an ultrasound. I might need to order 5 blood panels. I might need to order who knows what. So I've got to do that, get those orders in. Then I also have to diagnose you. I have to come up with a diagnosis. What does all this mean? Well, here's what it means based on my understanding of what's before me. And then I have to come up with a treatment plan for you. And so then, and it's not over, because then all of that information, I'm making quick notes on your chart, but then I will go back later on, usually that night, and I will fill all the rest of it in. So that's where all the time goes.
Yeah. So it's not like you said, 7 minutes with you, 5 to 7 minutes. Like
Exactly.
there's so much download in that 5 to 7 minutes that has to get put into the system.
Yes, precisely. And so and I'm not saying,
And this is not just for insurance basis. This is
yeah.
literally legally
Hmm.
a primary care provider is having to do this charting because their license is on the line if
Mhm.
something isn't caught, if
Right.
something is missed,
Right.
or if something isn't treated
Mhm.
correctly.
Right. And that's not, I mean, mistakes happen all the time, right? We're
Yeah.
we're human and we're fallible, except that a reasonable person should be in the medical field should be able to look at your notes and say, "Oh, yes, I see exactly where you were going here, and yes, based on the patient that was presented before you, yes, that is a reasonable thing to conclude." So yes, but these are legal documents that we put together. Your charts are legal documents. They can be subpoenaed. So yeah, they have to be in a certain way.
Mhm.
Um, so I think the next thing that I want to talk about is, and this is just a real quick topic. So sometimes patients hear us using medical terms, and a couple of these can be very offensive to patients. And so one of these terms is we use the word complaint. And complaint in the general population, that's a really negative sounding word. Like if somebody is complaining, it sounds like they're griping about something, right? And but in medical use, we call it a chief complaint. So a chief complaint is what you're walking in for that day. And that's what has been used for 100 years. And so we abbreviate it CC in our chart notes. They're the chief complaint of this patient or patient complains of. And so it doesn't mean that you're complaining. It literally just means what are you there for? So please don't be offended by the use of
What are you complaining about
I
today?
know, I know. Your mom always told you to stop complaining. Um,
And now your doctor
yes,
is too.
yes, that's right, that's right. So, no, your office doesn't think that you're a complainer, that's just the word that we use. And then the next word is the word denies, and so that's another word that is very commonly used in charting. So, we ask you lots and lots of questions, and the things that you answer yes to are incredibly important, but just as important are the things that you answer no to. So when you come in with a urinary tract complaint and I ask you, have you had a fever? Have you had chills? Have you had night sweats? I'm trying to determine one, if you have a UTI, and two, has it gone septic? Has it spread to the rest of you? Do you have constitutional complaints, right? And so complaints. Um, yes, do you have constitutional symptoms? And so that no, that's part of my charting because if somebody comes back and looks and says, "Yeah, but did you check to see if they were septic? You didn't
Uh-huh.
even ask about this." No, that has to go in my notes. That's called a pertinent negative, that the patient said, "No, I have not had." So we say patient denies.
Okay.
And often we'll say, like, patient denies alcohol use, patient denies drug use. And it sounds like we're saying, "Oh, they denied it, but I think they," but it's just literally the word that we use.
It's more a legal term.
Exactly,
Yeah.
exactly. So
So
we
not only are you a physician, you're a lawyer too.
yeah, well, yes, yes, and if you're not, you're probably in some trouble. Um, yeah, so, then I think the next thing I'll talk about is just the complexity of people. Any questions so far? Do you feel like this is,
No, I
useful?
think I want to finish this, but then something that came up too is maybe even types of physicians. Like there's a DO,
Oh, yeah,
PCP,
yeah, yeah.
like maybe defining
Yeah.
those terms too would be helpful.
Yes.
Like when somebody is even looking for a physician or
Yes.
a primary care, like what things
Mhm.
differentiate.
Yes. Okay. Yeah, and I'm gonna make some notes here, and we will get to that.
But
NP.
I think this is super helpful because, you know, whenever I have gone to the doctor, like I just assume it's an open book. Like
Right.
I'm here to see you. You are basically here to serve me.
Yes.
And
Yeah.
so there, I think there's just some basic knowledge that we all need to have when we set up these appointments. And I
Mhm.
think when we're setting up these appointments, not being as vague is probably what we generally
Mm.
are.
Yes.
Because if we can be more descript maybe when we're setting up these appointments,
Mhm.
then maybe there's less of a time commitment in the office of trying to dive into why you're there, and you can kind of get more straight to the point.
Yes. Yes, that is so important. Let's spend a minute here. So I am very sensitive to people's issues. Sometimes people will have issues that are a source of embarrassment to them. Sometimes if they are of an older generation, they don't talk about things as freely as we do, and I get that. And
Mhm.
then there are sometimes when there is like, complaints of a genital origin. Those are really hard to talk about, and I understand that. So, um symptoms of like an STD, for instance. If you've got genital discharge, penile discharge, vaginal discharge, malodorous discharge, like that's hard for people to talk about. It's of a very sensitive, intimate nature, and it's hard to call up and talk to a front office person. And when
Mhm.
they say, "Why are you being seen?" Yeah,
I have strange things coming
yes,
out of me.
yes, I know, and it's like, people disclose things like that to us all the time, and they seem to feel more comfortable doing that, but to other people that they may see as not as clinical, it's really hard.
Yeah.
But if you can get past that and just know that our front office people, they are extremely well versed. Like, they are incredibly adept at handling medical situations. They learn right alongside us. They are um, really knowledgeable, helpful people. And they're also extremely compassionate and sensitive. They understand how hard it is to talk about these things. And so, yeah, please don't be afraid. Know that we deal with this every day, day in and day out. And the more information that you can give us, the better I can prepare for your visit. So the night before, if I get a complaint like just need to see the NP, I have no idea.
It could be from, I just have
Yeah.
a sniffle and I don't know how to get rid
Yes.
of it, to like, I think I'm dying of cancer.
Yes. No, I found a testicular lump 5 years ago, and now it's growing. Oh,
Yeah,
okay.
that would have been nice to know.
Yes, I'm like, I need to see what the protocol is. So like, yes, there are things that I can prepare for you if the more open that you are. So, yeah, there's that. And let's see, where are we going next? Do you want to talk about like the types of visits? Shall we get into that? Or do you
Um,
want to talk about complexity of patients? Maybe we should talk about that.
let's uh let's do the complexity of patients. Yeah.
Okay. So, one hurdle. So 50 years ago, primary care looked much, much, much different. We had patients on maybe one medication, maybe two if they were a really complicated cardiovascular patient and they had a couple of things wrong. But now we have so much complexity built into our patients. I've got patients with 8, 10, 15 complaints, right? And I say
And
complaints,
again, complaints
yes,
just means,
it just means issues. Like,
yeah,
these are
like,
their issues. These are their diseases.
yeah.
These are their symptoms. And so they're also on 4, 10, 15 medications. Okay. They also may have substance abuse problems. They also have psychiatric issues. And so you get all of these diseases and symptoms and issues in the same person, but then you also get all the medication that comes along with that.
Mhm.
And that is all playing within the same organism. And here's the thing, when drug studies talk about possible side effects, they they don't know your specific physiology. They don't know your specific um, cornucopia of medications that you have to take every day. When they do drug studies, they don't study like, hey, we're going to put our study drug into a body with these other 9 drugs and see how it plays. No, that's not how it works. They put a drug into a single agent organism and say, "Oh, okay, this is what it does in the absence of anything else." But that's not what we're dealing with. We're dealing with patients on all of these medications. And so when you come to me with a symptom, I have to, like, within seconds, I have to look at your medication list and decide, huh, is this possibly a drug-drug interaction? Is this possibly a side effect of a new medication? And now add in 30 supplements that people are taking daily. And I have to know about that too. And it's
That's
just,
gonna be a whole nother episode
oh,
that we're
yes.
gonna do because we were talking yesterday. I was like, we see on Instagram like take this
Mhm.
XYZ for and it does this. And it's
Right.
like, oh, that sounds simple and easy and it's a natural supplement. But
Mhm.
as a primary care physician, they're saying, well, no, that actually interacts with this drug that you're taking. And so therefore it's actually not just a one size fits all.
Right. Right. And a lot of times there's no literature to support what supplements interact with.
Right.
There isn't. Now, there are some common ones that we all should have knowledge of, but for a lot of these newer supplements, we have no idea. So what I have to do is figure out what is known about this supplement, how does it interact with the body biochemically, what does it do, and then what could it potentially be interacting with the drugs that this patient is on. And so it's very complicated. So
So think about that. Like, you're going into this office visit. They have a very vague information on why you're even there. And then they're having to ask and think about all these questions to ask you if it's not in your
mhm,
chart.
mhm. Yeah.
So the complexity of a simple office visit has just escalated,
Skyrocketed. Yeah.
even for a simple common cold.
Right. Yeah. No, that's without a doubt. Without a doubt. Um, so yeah, we've got patients with many medications. We've got patients with many medical conditions. We've got patients that have not had care in years. And so then it becomes like, okay, we have to come to agreement on what is important. So I may have a patient with a blood pressure of 200 over 100s, okay? And but to them, I got to get this weight off. That's the most important thing to me. And it's like, okay, so now we have to have a therapeutic conversation and I have to make my case for, listen, I care about you and in my capacity as your primary care provider, it's my obligation to tell you that this high blood pressure, if we don't address this, here's where we're headed. Now, it's still up to you what the most important thing to tackle is, but I would be remiss if I did not say, this is first on my list for you.
Right.
Um, so there's that conversation too that needs to be had because often people will have things going on that are way more serious than maybe than what they know.
Mhm.
And and they have come to you for something completely different. And so ultimately though, at the end of the day, you know, I'm a nurse practitioner. I am not a physician. The model that I was trained in is that we get patient buy-in. We need to understand what is important to that patient. And again, at the end of the day, if I have explained to you everything that I'm concerned about and you still say to me, I don't care about that, this is what I care about, then I'm going to come alongside you and we're going to try and help you out. So, yeah, that just adds to the complexity. And also, if patients haven't had any labs in some time, like I might need some lab values. There are a lot of things that aren't necessarily symptomatic. Like, for instance, if you have elevated blood pressure, that's called the silent killer for a reason. It's because you won't get symptoms until, again, you're 200s over something. And then you might get a headache, you might have some blurred vision. There are some things we're looking for, but you may not associate that with your blood pressure,
Right.
but I will if I can get that value. So, blood sugar. There are people walking around with blood glucose in the 300s, 400s, and uh, as far as they know, they're asymptomatic, right? Like, "Oh, I can't get out of the toilet and I'm thirsty all the time." All right, well, let's let's get some lab values here. So, yeah, we need those lab values. It's important. And so I may have to send you out without a diagnosis, um, until labs come back, and then I have to have you come back
Yeah,
so we could talk
that
about it.
that was one of the things that when Andreas first started her clinicals was like these people come in with one thing and then they're like, I have, oh yeah, I forgot I have this going on too. And she's like, I don't have time. Like,
Yeah,
which not saying that
right,
directly as direct as that, but like I'm gonna have to have you come
yeah,
back. And then they get frustrated. It's like, well, I'm here already. Why do I have to come back?
right.
And just like what she explained to you guys before, this time is so
Mhm.
valuable. Like the little time that she has with you has to be so fine tunedly spent.
Right. And on the one side, we have the tyranny of the clock, right? Because
Right.
ultimately, the practice owner, she is an insanely talented and brilliant nurse practitioner, and she has taken the risk of opening this clinic. It's her business, like this
Right.
is her livelihood,
Yep.
and it is also my livelihood. I'm her employee, and ultimately, like, we have to keep the clinic open,
Right.
and we have to pay for staff. They earn their money every single day taking care of folks, and so we have to keep the doors open in order to help people. And in order to do that, we have to see a certain number of patients a day. So we're in this really special little spot where we can take insurance, but what that means is I have to play within the insurance model. And
Mhm.
so what that looks like, I've tried to explain a little bit today why I have to have you come back, right? Why I have to say, listen, that other thing that you've got going on, I really want to give it the time that it deserves. And so I'm going to need you to make a separate appointment for that. And I know that's frustrating for people, but I just cannot get the information that I need when I have 2 minutes left in this visit. And we've talked about, your chief complaint from what we said we were gonna be spending our time on today. We've already spent that time. So,
Mhm.
yeah, come back and see me.
Yeah.
And that's how this model works.
Yeah. Which is frustrating because you're like, well, I spent a $30 copay.
Yeah.
So then
Yep.
therefore I'm gonna have to come back and spend another $30. Well, now I'm up to
Yeah.
60. And
Right.
so I have to spend $30 for every single visit. So yeah, but like she says, this is the reality of the system
Right.
under this model.
Yeah.
And like and also it reiterating that these people, these providers truly do want to see you and get to the bottom of all your issues, but under the model of what they have to get to in a day, they just
Mhm.
physically, literally cannot.
Yeah. Yeah, it's, there has to be sleep. I've got basketball games that are like, this is my one shot to see
Yeah.
to see my kid play
So,
ball, and
you know,
yeah,
just like me with my personal training, like I want to see you succeed. I want to be there for you, but I am not available 24/7.
right.
And so neither are these doctors. They have a life. They need a life.
Mhm.
And so yeah, it's just the reality of any type of job, really.
Yeah, and the
At the end of the
bottom
day, it's a job.
yeah, well, it is, and I really feel strongly that it's a calling, it's a
Yeah.
vocation, but yes, I mean, it's how I put food on the table, and it's how I take care of myself and my family, um, Uh, but it just so happens I have the privilege of being responsible for people's care and their health, and I take that really seriously. But if I burn out, then I let everybody down because I can't do it anymore. And so
Exactly.
that's the reality of what's happening. Um, so yeah,
So
l-
why don't we go into okay, we understand the
yeah. Do you want to talk about the types of providers?
yeah, that's what I was gonna
Oh,
say.
okay.
It's like so we know what a visit entails of, but okay, I'm looking for a primary care physician.
Mhm,
And then I see all these letters after their name when I'm looking in my insurance search box, right?
mhm.
And I'm like, I have no idea what a DO, MD, PCP, NP, PA. I mean, I know what they say, know what they stand for, but I don't know what they actually mean.
Yeah, yeah. Let's definitely talk about that. Okay, so um, first of all, I want to start off with there are two branches of healthcare. That's what I'll say. There are two standardized branches of how to deliver healthcare or primary care to people.
Okay.
And one of those branches is given the name medical, the other is given the name nursing. So
Okay.
there is a medical model in terms of taking care of people, and then there is a nursing model in terms of taking care of people. All right. So under the medical model, the very tip top of that um, hierarchy, all right, is the MD, that is a medical doctor, or a DO, that's a doctor of osteopathy. And I'll explain the difference between those two. It's almost indistinguishable these days, but it didn't used to be like that. So
Okay.
I'll explain that here in a minute. And they are very much trained in that medical model. All right. It's a completely different way of looking at patients, of delivering patient care. It used to be the only way of delivering health care. Um, and then I will also include a physician's assistant or PA under under that medical model. They are trained in the medical model. Okay. Now, and I'm trying to find the date. I should know this. Yeah, okay, 1980s. There we go. All right, so now let's talk about the nursing side of things. Um, so, an NP, the very tip top of the nursing model, is a doctorate in nursing practice, and
Okay.
that's what I am.
Okay.
So, we top out at a terminal doctoral degree also, but we are trained in a nursing model. So, an MD or a DO, they don't have to be anything before they are a doctor. A nurse practitioner has to be a nurse before you can be a nurse practitioner.
Why is that?
Well, because so when you look at physician schooling, and when I say physician, I always mean MD or DO.
Okay.
Um, when you look at their schooling, they go for many more years than a nurse practitioner does, and I'll
Okay.
explain that here in a second. But they go through residencies, they go through training, they do thousands of hours underneath other physicians, um, and that's how they learn their craft, all
Okay.
right? So in a nursing model, you start out as a nurse and you learn to care for people in that nursing model. And
Okay.
often, people who go on to become an NP, they have spent years nursing, being a nurse, seeing patients in all circumstances, and there is no working in nursing without learning every single day. So there is a lot of very practical education there that
Okay.
occurs on the job.
Yeah.
Then they pursue, so for instance, I came out of the ER,
Mhm.
and I pursued a doctorate in nursing practice. And so I spent 3 years, 9 semesters studying to be a nurse practitioner. I did nearly 2,000 hours of clinical time during my education. Took, you know, a lot of classes, a lot of coursework. And so that is where our degree tops out. All right.
Okay.
And then we both can deliver. I am a family practice nurse practitioner. And so there are family practice MDs and DOs.
Okay.
We will look at patients very differently, okay? And I won't speak to the medical side of things because I wasn't trained in that model. However, I will say that when I was looking at um, going to school to become a primary care provider, I did look at the difference between a nursing model and a medical model. And the nursing model of caring for people is very holistic.
Mhm.
We don't separate the brain from the body. We don't put things necessarily in silos.
Okay.
We put the whole body together. We look at the individual in front of us. I like to say that we look at the patient that has the disease rather than the disease that has the patient.
Ooh, I like that.
And so that resonates with me. That is
Mhm.
how I see the world. That's how I practice as a nutritionist. And so that's why I went to nursing school rather than pursue a medical education.
Okay.
So it just really depends on patient preference. If you feel more comfortable in a medical setting, in a medical model, then, an MD or a DO might be your best bet for providing primary care. If you like the way that nursing care is delivered, then an NP would probably be your best option. Now, there are also physician assistants. Now, these folks, again, in a medical model, they don't have to be anything before they become a physician assistant, but they cannot practice independently of a doctor.
So they have to practice under
They have to
somebody.
practice under. Now, there is a legislative effort in certain states that is endeavoring to allow PAs to practice independently, but as you can imagine, that's not super popular with the medical establishment.
Because explain again the if you didn't PAs go through how much schooling compared to NP?
Well, PA program used to be 2 years,
Okay.
and now I think it's a mandatory master's degree. It used to be is it a bachelor's? I can't remember, but they now, I believe it's a mandatory master's degree, and I think it's 3 years.
Okay.
So that's like coming from no training at all to 3 years later.
And with a PA, you don't have to be a nurse before?
No, no, they
Okay.
don't have no, no medical. Now some of them come in, having been an EMT or having been, any number of things, like a
Okay.
medical
Yeah.
assistant or something like that. But no, it's not required.
Okay. So an NP still has more schooling than a PA.
Oh, yeah, yeah,
Yeah.
yeah.
And
And
then what's the difference between PCP and NP?
so a PCP now, a PCP, that just means primary care provider.
So it's just kind of a
It
label.
can
Like,
be anyone.
okay.
That is
So it could be the DO, the MD, or the
Yes,
NP
yes, or the PA.
or the PA.
Yes. So
Okay.
if you see a PA, there is a physician
Over
that
them.
is over them checking charts, signing
Okay.
off on things.
Okay.
A lot of PAs function very independently,
Okay.
but
They still have to have that
yeah,
licensure
yes.
over them.
And in most states, NPs practice completely independently
Okay.
without physician oversight. Um, so let's
So, kind of a recap.
Mhm.
If you prefer a more holistic view of the body and care, you're gonna probably want to look for that NP on a title.
Yes. Now, that's not to say
But also, I want to get back to the certain states because, like, um, Colorado, Kansas, New Mexico, Idaho, those are the ones that we've recently looked at. I know there's more. They allow NPs to practice independently. Is that
Mhm.
the correct term?
Yes, and there are degrees of independence. Most states in the country allow complete autonomy. It's called full practice authority states.
Okay.
And that means NPs, we have our own practices, we have our own businesses, we don't need physician oversight for anything. There are certain states, however, that are kind of regulation heavy. These typically have very strong medical lobbies, and they put NPs underneath the purview of a supervising physician.
So that would be your DO or MD.
Yes.
Yeah.
Mhm.
So, yeah. So if you look up your state, that
Yeah.
would probably would be the best starting
Mhm.
point of like, okay, does this person have to um be under a DRMD? Uh, I don't know if it necessarily matters for the patient per se. It's
Yeah.
probably more of the physician it's themselves if they
Mhm.
have full practicing authority. But just as a person coming in, you
Mhm.
might be a little bit more educated and understand, hey, this person because of where I'm living isn't full practice authority.
Yeah.
They actually have to have an MD or DO over
Yeah.
them for the licensure
Right.
factor.
Yeah, and another thing I wanna say is this term, uh, doctor.
Mm-hmm.
So, I I would never introduce myself as Dr. Crane. Do I have a doctorate? Yes. In an academic situation, sure.
Yeah.
But but in a clinical situation, no. And this again, it really speaks to, I think it speaks to a couple of things. One, I don't ever want patients thinking that I'm a medical doctor because one, that's not how I practice. Two, I didn't receive that particular education. I received a nursing education. That is
Yeah.
the model that I view everything under. And three, I, if patients call you Andrea versus Dr. Crane, it seems like there's a little more equality there.
Personal touch, if you will.
Yeah,
Like it's
yeah.
more of like a friend
Yes,
ish.
it's more of an equal relationship, and I just think it's really important for patients to understand that you have full autonomy over your healthcare. And
Yes.
I am here
Yes.
to help. I am not
Yes.
here to wag my finger in your face and tell you what you ought to be doing, and that I'm going to be mad at you if you don't make the decisions I'm telling you to make.
Yeah.
Yeah,
So I think we should make this a two-part series.
that's probably a good idea.
And because we went over a lot of information
Hmm.
today, and I think the next part of this is going to go diving deep into what these visits actually look like and maybe some things that might help you in understanding, hey, this is what I actually should be asking for. Because I know, like, when I go talk to a doctor, like, for example, when I went to set up a primary care last year when we moved, um, I mean, I racked Andrew's brain on all this, so I felt like I was coming more prepared. So I want you guys to feel that preparedness when setting up these. One, if you're establishing new care, or if you're just setting up maybe an annual wellness visit or follow up visit. So why don't we stop this episode here,
Hmm.
and we will continue on with what those visits actually look like. But this was fascinating.
Awesome.
Yeah.
Awesome.
Like I don't think people just well, I know because I didn't know. I didn't know what really truly went into all the back end of this is. And I think it's important as somebody who wants to be educated in their own healthcare to understand why visits are so short, why they don't feel like they're necessarily being heard completely,
Hmm.
and why there probably needs to be multiple visits in order to fully have a full grasp on your health. So, thank you, Andrea.
Yes, of course. Thanks for the questions.
Yeah, and take a listen to our next episode. It will air the following week. And as always, if you have questions, if you want us to dive deeper into a part that we might have just kind of brushed over in for you, then please send us an email at our email. It's all in the show notes, but it's askaapodcast@gmail.com. Or you can easily find us on the social medias, which is also linked in our show notes. So we will catch you on the next episode.
Bye. The content provided in the
NCAA podcast is intended for informational and educational purposes only. The podcast is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. The information and opinions expressed in this podcast are solely those of the individuals involved and do not constitute medical advice.